Thank you very much for the introduction, and it's my pleasure to present you the first. Okay. Perfect. Okay. I'll present you the first findings of the global sarcoma patient diagnosis survey we conducted from the SPAGN organization. First of all, I give you a short overview of today's talk, giving you a short introduction with its background, and then the methods we use, and going to the results with the focus on time to diagnosis, the change of diagnosis and misdiagnosis we use, and then further findings which are important, and then give you at the end a conclusion. So before diving into the data, let's take a step back and look at how the ideal diagnostic pathway for sarcoma patient should actually look like. And it should be linear, it should be timely, and it should be efficient. So the patient would recognize something unusual and then see a primary care physician. And he or she would then refer the patient to the right specialist, or even better to sarcoma expert center. And they would do the appropriate diagnostics and then came up with a diagnosis and then initiate treatment. However, as we all know, this is not the case for many sarcoma patients. It looks totally different. So the patient has vague symptoms. They see multiple doctors until they end up with their diagnosis, and that takes sometimes months or even years. And
it's better to use that microphone.
Okay. Yeah, that's not a problem. Maybe that's better, true. So as we all know, sarcomas are a rare disease, and we do have a high heterogeneity, and the rarity and the heterogeneity in sarcomas lead to a low awareness among healthcare providers and a delayed and a complex diagnostic process, even in expert centers. And patients do have changes in diagnosis and misdiagnosis reported up to 50%. And this leads to lower survival rates compared to common cancers. So it would be super important to have early diagnosis to improve what we heard before, the patient outcomes like health-related quality of life, which was mentioned, or the survival rates. So the aim would be to shorten this diagnostic interval, and I show you in the next slide how we define the diagnostic interval. And then we want to identify the risk groups which have the prolonged diagnostic intervals. So coming to the definition, what we used for the diagnostic interval, actually it's divided into two parts. We have on the one hand side the patient interval, which is the time to seek care, like coming from the patient recognizes the first symptoms and then until he visits or she visits the doctor. And then we do have the second interval, which is the care interval. So from the first presentation to the doctor until the current diagnosis. And the total interval is then summed up to the full diagnostic interval. So our objective, we aim to systematically describe and quantify these diagnostic experiences of sarcoma patients, and specifically we want to look in regarding the diagnostic intervals, the two parts, the patient and the care interval, and the occurrence of misdiagnosis. And secondly, we want to identify then the risk groups and the barriers contributing to these delays. And so we conducted a cross-sectional online survey for patients and caregivers with sarcoma diagnosis. It was conducted last year from July to December over a period of 6 months, and included were all types of sarcoma patients and also caregivers of those patients. It was conducted in 49 countries around the world, and the questionnaires were available in 18 languages. And we used a combination of single choice, multiple choice, and also open-ended questions. The dissemination was carried out through flyers and social media initiated by SPAGN and all the national partner organizations to ensure a broad outreach and engagement. And here, for instance, you see in Germany we printed little cards with a QR code on it, so the patient could just log in the questionnaire and enter the questions. So we assessed 3,316 patients for eligibility. We had to exclude 1,502 patients because they declined to participate or they didn't submit the questionnaire at the end. And so we screened 1,814, and at the end we had to exclude only 11 patients because they didn't have any sarcoma diagnosis, and 1,803 patients were included in the final analysis. So coming to the first results regarding the characteristics, the median age was 53 years, but there was a range from 0 to 89 years. We included more women, with over 70% women and only 28% male. And regarding subgroups, almost 60% had a soft tissue sarcoma, 22 a bone sarcoma, and 15 GIST, and then the rest others. The respondents came from all over the world, mostly from the US and Germany, the blue parts, and Africa was underrepresented, but from everywhere. And regarding the age groups, most of the patients were between 20 years and 64 years, with the highest peak in the age group 40 to 64. Regarding primary tumor locations, most of the tumors were located in the trunk, with almost 60% and 30% in the extremities. And the distribution regarding the country income level, most of our respondents came from higher income countries with 88%, and the rest came from the higher and the lower middle income countries. And regarding education, we had included more educated people, with 31% having a university degree or 25% having a bachelor's degree. Regarding the results to time to diagnosis, here divided by sex, remember the blue part is the patient interval from the first symptoms until they see for the first time a doctor, and the yellow part is the care interval from seeing the first time a doctor until they get the current diagnosis. And here we saw a total interval of 65 days in the median for male and 90 days for women. And what also sticks out is that we had a huge range in those intervals, from 0 days until 20 years in the patient interval for female. That's a huge range we saw. And this is the case also for all the other deviations. So here you see divided by age group, and most of the patients with the longest intervals came from the age group 20 to 64 years, with a median of 95 days, and huge intervals until 20 or 16 years in the patient interval, and 8 and 12 years until in the care interval. Here the diagnostic intervals divided by subgroups, and here we see that the intermediate group and the not further defined group, they here we see a total interval of 225 days and over 200 days in a not further defined group, and less days intermediate in the other groups. Here, divided by primary tumor location, we have the longest interval here with 120 days in the median in the head and neck group, and followed by then the extremities with 116 days. And also here, huge ranges until 10 years. Here the diagnostic interval regarding the country by income level, and we saw the longest intervals in the high income and the lower middle income country with 90 days in these groups, and also here huge ranges up to 20 years in the patient interval for the high income groups. Coming to the next part, this was the change of diagnosis or misdiagnosis. Here you see the frequency of misdiagnosis. The question was, has your diagnosis changed in the course of your journey as a patient? And 22 patients said no, but over 22 patients said that they had a misdiagnosis or a change. And then we did ask for those who said here yes in the yellow part. We asked how many times did the diagnosis change before the current sarcoma diagnosis? And most of the patients said it changed only one time, with 61% here, but also 16% said 2 times, or the rest even higher, more than 2 times they had a change in diagnosis. Divided by sex, you see similar results between male and female. Over 70% said they didn't have any change, but over 22 here for male and female did have at least one change in diagnosis. The same here, the question, how often did it change? For most of the patients, it did change only once, but we see that there are patients which have 2 or 3 changes in their diagnosis during the process. We had the most changes, here the yellow bars you see in the age groups 20 to 64. We did have changes from 24 and 23%. Divided by subgroups, we had the most changes in the subgroup of the intermediate tumors with 28%, and not further defined tumors with 29%. Regarding the primary tumor location, here most of the patients who had a change where the tumor was located then in the organ systems with 23%, head and neck here, 28% was higher, and then followed by here the extremities and the organs. Divided by income country, most of the changes, so we had 73% had no change in the high income countries, and 22 had a change, and similar results in the other groups, a little bit less here. So additional findings, what we found, we did ask, did you encounter any challenges or barriers in obtaining a diagnosis of sarcomas? And what sticks out with almost 40% said they had misdiagnosed or delays in diagnosis, and then followed by the lack of awareness about sarcoma among healthcare professionals. And the other barriers which we faced were the difficulty finding a healthcare professional with sarcoma knowledge, and long waiting times for appointment for getting the test results in almost 30%. And here down we see on the patient side also a lack of awareness and education on my side as a patient, and financial barriers which were mentioned from the patient side with 26%. Then we did ask the question, did you receive any of sarcoma diagnosis at the reference sarcoma specialist center? And we saw that 55% said yes, they did receive their diagnosis there, but the rest said no, they didn't. So 38%, or it was not applicable. Next question was, how far did you travel to seek advice at a reference sarcoma specialist center? And most of the patients drove less than 60 miles, here almost 60%, and followed by the distance between 60 miles and 190 miles, 20%. And then we asked how many healthcare providers did they consult before they got diagnosed, and only 11 said they consulted only one physician, and most of the patients saw at least 2 or 3 physicians before they got diagnosed, 24, almost 25%, and here the same. And the rest here, at the end, you see they saw more than 3 care providers before they received their diagnosis at the end. And then for sure we want to know which of the following physicians they have seen before they got that final diagnosis. And almost 60% here saw a general practitioner before they got diagnosed, followed by the radiologist with 26%, the surgeon with 35%, and the oncologists with 26%, which were the most consulted ones. And then we want to know what type of physician first suspected then that the sarcoma diagnosis prior to the current diagnosis. And here we saw that in 16% it was a surgeon, and the oncologist in 13%, and the radiologist in 15%. So the general practitioners were most consulted with over 50%, but only 7.7 suspected a sarcoma initially. And the surgeon played a key role in both, on the one hand side, the consultation and also the early recognition of sarcomas. And the radiologists and the oncologists, orthopedics, and pathologists are crucial in raising early suspicion. That was also interesting when we asked what were the main symptoms or complications that patient experienced before their diagnosis. And in almost 50%, the patients said that they had pain, and then followed by, in 42%, by swelling and lump, and 20% said they had fatigue. And what also was interesting, that 11% didn't feel anything. It was an incidental finding for them. Okay, but we do have to name a few limitations we faced. So there was a selection bias of the cohort. We used the online questionnaire, which was distributed mainly by social media. And so that was distributed by the patient advocacy organizations. And so there was an underrepresentation, I think, of elderly patients, which were more morbid, and we excluded people with who didn't have access to the internet, because it was only an online questionnaire, not paper-based. And the respondents were likely more engaged with the national partner organizations and thus receiving more support than the average sarcoma patient. What we saw, the male respondents were underrepresented because we only included 30% were male, and despite we know that there is a male predominance in sarcomas reported, and we had more patients coming from the high-income countries, what we discussed yesterday. So 11% of the response came from low and middle-income countries. And what we also saw that our patients included had a higher educational level than compared to the general population. And because the data are patient-reported, and therefore there is subject to recall bias. However, there are several strengths in our study. So it's a first study to explore the total diagnostic interval divided by those two, the patient and the care interval. across all sarcoma subtypes, and we could include patients from all over the world with a wide range of tumor characteristics, the patient demographics, and healthcare and management-related factors. So the diagnostic timelines in sarcoma are highly variable, what we saw, with huge ranges, and both the patient interval and also the diagnostic interval contribute significantly to the overall delays. And this highlights the complexity of the diagnostic and the referral pathway for both, for the patient and also the healthcare professionals. And we are conducting at the moment ongoing analysis to further explore the patient and also the system level factors contributing to those delays. And with that, I want to thank you. I want to thank SPAGN and especially Catherine for the initiative, for conducting everything. I want to thank all the organizations who helped to distribute the questionnaires, and I want to thank the patient and caregivers who were willing to share the data and to participate. And thank you very much. We're looking forward to further results and the discussion. Thanks.
Thank you very much, Verena. We had planned a discussion session, but in view of the time, maybe we can have just one or two questions. I have a very pressing question myself, and that's not maybe just to you, but to the audience. What could we do about the gender bias? This is something that we very often see in questionnaires. It's the women that respond, and where are the male? What can we do about it?
Okay.
May I say, first of all, congratulations, because it has been a big effort and are very important data. I think I'd like to link you to one of our PhD students who's working on this in a clinical trial, and I see some overlap, some difference in the outcome. I think that is very interesting. We also did a project, or are running a project together with the general practitioners, and I must say I learned a lot by doing that. First of all, we went into a database of in the region in the Netherlands, where we looked at back at patients who finally were diagnosed with a sarcoma. What were their symptoms when they came to the GP? And as you can appreciate, for bone sarcomas, it was more, I would say, symptoms that you can imagine that are related to a final diagnosis. But we saw also a lot with the soft tissue sarcoma patients that their diagnosis was made based on urinary tract infections, visits, or hypertension. So maybe you recognize it that patients are with a GP and then say, oh, but well, listen, I also have a lump here or there. And then during that visit, for something else, the diagnosis, well, at least it was the start of a pathway, let's call it like this. And another thing that we learned is that at least in the Netherlands, the coding for some symptoms where finally patients who have a sarcoma present with is not clear. So they don't have in their system a code in which they can really say, I suspect a soft tissue sarcoma, something like that. That was, well, for me, quite unexpected. I thought, well, if they don't, if they are not able to code, well, how can we learn from these databases? So we will work with them also on changing that in due course, hopefully. But I think these data you presented are so important to combine with other diagnostic interval delay data, so that we also can see what can we change here. Some things we can't change, but some maybe we can.
Yeah.
So thanks a lot.
Well, great. Thank you.